Thank you very much. Good evening, everybody, and welcome to our webinar series, which are being held every Wednesday. Today, we are having the 154th webinar that is being presented right from 2020. Just for all of you to know, the Indian College of Anesthesiologists, you can all become members of the ICA by logging on to our website, and it's very simple, and you can go online and become a member. We have Yearbook of Anesthesiology, which is published every year, and the 12th edition can be bought on this website of www. Yes, we must remember that in November, we have our annual conference here in Bangalore. This is the 4th International and 14th National Conference of the Indian College of Anesthesiologists. Please do join. You can start registering. Today, we have our webinar on neuroanesthesia, topics less discussed. Very important. And for this, we have eminent speakers. The moderator is Dr. Mukul Kapoor, and the speakers are Dr. Gaurav Kakkar, Dr. Ketan Kulkarni, and Dr. Rahul. Thank you very much, and welcome to all of you. Next week, on the 5th of July, we shall be having another webinar on the anesthetic concerns in blood disorders, another very important topic. And to continue, just for all of you to know that on the 12th, we shall be having our 3rd anniversary, in which we shall be having a very special webinar. Today, to introduce our moderator, we have Dr. Mukul Chandra Kapoor, who is very well known to all of us. He is not only our chief involved in the yearbook, the editor of the yearbook of anesthesiology, plus he's a very important member of our ICA. He is a chief consultant at the Amrita Hospitals, Faridabad, and has been the Dean Academics of the Indian College of Cardiac Anesthesia. So welcome all of you and have a good webinar today. Thank you. Mukul, you may please start.
Thank you very much, ma'am, for the kind introduction, and welcome all people who are logging in and hearing our webinar. This is another webinar in the series which we have been presenting from Amrita Hospital, and today we have decided to present to you neuroanesthesia, topics which are less discussed. You must have heard a lot of topics on neuroanesthesia, but we have tried to pick up topics which are less discussed, and basically wanted everybody to know about certain aspects of specific cases in neuroanesthesia, and also talk about a little bit about positioning in neuroanesthesia, which is a very important part of neuroanesthesia. So to begin the session, I would first call upon Dr. Gaurav Kakkar. Dr. Gaurav, can you share your first slide? Dr. Gaurav Kakkar is the lead consultant neuroanesthesia at our hospital and Amrita School of Medicine and Amrita Institute of Medical Sciences at Faridabad. Dr. Gaurav Kakkar is an alumni of AFMC Pune. After his stint at AFMC Pune, he migrated to the United Kingdom. And in the United Kingdom, he trained at Walton to become a neuroanesthetist. He had a good career there, a consultant neuroanesthetist in the NHS. And then he decided to come back to his home country. And initially, he joined Medanta, the Medicity, and now he's with us at Amrita. Dr. Gaurav has got keen interest in not only neuroanesthesia, got a keen interest in even safety during anesthesia. And he is a prolific speaker, and I'm sure you're going to enjoy his talk once he starts presenting it. And he's talking about anesthesia for pituitary surgery. That is, normally we see pituitary surgery being done in which both the ENT surgeons and the neurosurgeons are involved. And the approach is a little different from normal approaches for neurosurgery. Over to you, Gaurav.
Thank you, sir. Thank you for the kind introduction. And thank you for the ICA for giving us the opportunity to discuss things. Moving on to the first topic of the day, anesthesia for pituitary surgery. I hope I am audible and my slides are visible.
Yes, please.
Yes, you are.
Great, thank you. So I bring to you greetings from Amrita Hospital, Faridabad, and there are no financial disclosures to make. I'm going to be talking about the common, one of the common surgeries in neuroanesthesia that we perform for is the pituitary surgery. We've over the years now moved on to minimally invasive surgery for pituitary tumors. And in a hyphenated form, it's called as TNTS, which is transnasal transsphenoidal surgery. That means you do it via an endoscope through the nares, making small holes into the sphenoid bone and get to the access to the skull base where the gland is located. So I'll talk about the relevant anatomy and physiology quickly in 20 minutes to cover the key aspects, preoperative evaluation, which is the key and the foremost thing in this category, the common conditions that come to us, the key anesthetic considerations, the post-op complications, and some key tips for people who are beginning their journey in neuroanesthesia. So to start with, pituitary tumors, they comprise of about 20% of all the operations that happen for primary brain tumors in neurosurgeries, and 10% of all intracranial neoplasms are pituitary tumors. Thankfully, most of them are benign, so we need not worry about them, but they present to us with different challenges. The peak incidence is around the 40 to 60 years age group. And the unique considerations in this category is predominantly the hormonal related endocrine issues that come out from these tumors. So when I was beginning to prepare for my exams, I was told whenever you go to explain a topic, you've got to classify or die. So to start with the classification, we can classify pituitary tumors as either considering their size, which can be either the small or big. So small microadenomas are tumors of the pituitary gland, which are less than 10 millimeters, and the bigger ones relatively fall into the category of more than 10 millimeters in size. So we term this macroadenomas. Or you can simply classify them into the functionality of the tumor. If the tumor of the pituitary gland is either functional or non-functional, that's the term you'll hear during the evaluation of the patient. So functional predominantly means that it is a hormone secreting tumor, and non-functional means that it is primarily a non-hormonal secreting tumor at that time. It could become or change later on. You could also classify them into the endocrine category of the tumor, in which it could be what kind of hormone secreting tumor it is. So a prolactinoma, which is a prolactin secreting tumor, a growth hormone secreting tumor, which gives us conditions like acromegaly, an ACTH secreting tumor, which is Cushing's, or the thyroid related tumors that gives problems from the thyroid gland. Now, the workup begins for these patients with the differential diagnosis, and all these categories sit into the differential because the pituitary gland lies somewhere in the middle cranial fossa in the place called the sella turcica, where this gland sits, and it has got the anterior and posterior lobes of the pituitary. Now, all these other conditions can also present and mimic, and it's very hard with a simple scans. You need a lot of functional scans and diagnostic neuroradiologists to work out the actual diagnosis of the tumor. As I said, it sits in the place called the sella turcica, just around the middle cranial fossa. So if you were to see this cross section coming out just behind the orbitals, you can see the two orbits where each optic nerve goes and makes the optic chiasma. Just underneath sits the pituitary gland. So any tumor that arises most commonly presents with pressure symptoms pressing onto the optic chiasma, and the patient starts presenting with ophthalmic symptoms. If you look at the relevant clinical anatomy, there are certain important structures here that are of very valued concern to us. And namely, the biggest concern for us is the two big vessels that are underneath the optic nerves of each side and come very close to the tumor or come very close to the gland. And this is the internal carotid artery, and all the branches surround this area. So namely, this is the primary concern for us during the most important approach, the common approach these days, which is the transnasal transphonoidal approach. This is one of the microscopic images of the anatomy. You can see the pituitary gland, and right there you can see the ICA. You can appreciate the proximity of the big vessels around this area. So at the outset, when you look at it, it all looks like a minimally invasive surgery, but you're dealing with a lot of tigers in the field around there, and hence comes the preparation. Coming back to some physiology of the condition. So we got two lobes, the anterior lobe and the posterior lobe. Most of the problems that the patient presents with comes from the hormones that are secreting from the anterior pituitary. So mainly the ACTH, which affects the adrenal cortex release of hormones, the growth hormone, which affects the skeletal muscle bone growth, the melatonin secreting hormones that affect the coloration of the skin, the TSH, which we all know, affecting the thyroid gland, and then the gonadotropin hormones like the prolactin and the other gonadotropins. The posterior pituitary plays its part in the ADH and the oxytocin, and that's where these conditions highlight. The other relevant physiology to mention very briefly is the part that it plays in the neurohypophyseal axis, where the posterior pituitary and the hypothalamus has the relation to play. And this predominantly brings to light the ADH and the oxytocin secretions. If you look at certain imaging, these are the MRI scans of the patient. You can see in one of these top left sagittal sections, you can see a little post-contrast structure hanging just above the sphenoid air sinus. That's the pituitary gland. You can see it enlarged in the image below, and you can see the same structure increased in size in a coronal section. So this is an adenoma of the pituitary gland. Similar findings, a macroadenoma post-contrast on a coronal section in an MRI scan. So when it becomes this big, it starts causing problems to the patient. And let us look at some common conditions which presents to the physicians, how they make way to us. Most commonest tumor of the pituitary gland in terms of numerical value is the prolactinoma. It doesn't reach us because mostly it is medically managed with the drugs, and very few of these will reach the surgical table. The symptoms generally in females are of amenorrhea, galactorrhea, and non-specific symptoms are there. Things that start to affect predominantly the patient, and they come to us, one of the bigger growth hormone secreting tumors, which leads to this condition called the acromegaly, where it is colloquially termed as gigantism. So you've got increased growth in the bone and the skeletal muscle. So there are big changes in the musculoskeletal stature. There is facial changes, large lips, large tongues. The airway change is important to us. The cardiovascular pulmonary changes, which we'll all discuss later. We have issues coming out from the acromegaly which are relevant to us, especially the issues of difficult airway, the OSA and cardiac things. We'll discuss them in detail in the subsequent slides. A few examples of the acromegalic, some of them go on to become celebrities though. The other common thing that comes up to us is the Cushing syndrome. So this is the ACTH excess causing a different pattern, predominantly due to the fat redistribution. It again gives us problems because of the cardiovascular and airway issues. Then we've got thyrotropic adenomas. These don't come as often as the Cushing's and the growth hormone tumors, because predominantly they can be managed with antithyroid medications. So if we were to just summarize them in a slide, then we've got the growth hormone tumors causing acromegaly, the ACTH releasing causing Cushing's, You got the gonadotropic prolactinomas generally don't need surgery. So this is a quick summarization of the anatomical and the physiological applicability of these tumors. Now coming out to what does the patient present with? So the patient presents with two primarily issues. Either the tumor grows in the size and causes the local mass effect around its area, or the problems come out from the excess secretion of the hormones. So the most commonly presenting features are the mass effect features, because as the tumor starts to grow, increasing in size, the first and foremost thing that the patient starts to feel is the things of raised ICP in subtle formats like the headache, nausea, vomiting. If you look at the eyes in terms of in the clinics, you'll start seeing papillodemas. And as the tumor starts to grow, it starts to press either around the chiasma or on the optic nerves and cause the typical visual field defects. And for the MCQs, it comes as this bilateral homonymous hemianopias. So as the mass effect grows, you've got the typical raised ICP issues with visual field defects being the predominant. The other things are the hormonal effects, which typically depends for the typical tumor that exists, whether it is a growth hormone secreting tumor or an ACTH secreting tumor. And that's where our preoperative evaluation comes, which is of extremely important. And unless you know the background of the tumor, you would not be able to concentrate on the preoperative evaluation. Now, I would say that I personally would follow an ABCD approach for everything, and I do that for these patients as well. So your preoperative evaluation must start with the airway, and the airway can be challenging for these, whether it's a Cushing's patients or a acromegalic, and they can have subsequent challenges going on to the breathing system where they can have issues with obstructive sleep apnea and so forth, and they could be with patients who need regular CPAP or night CPAP at home. You can follow that with the cardiovascular system, because most of these conditions with excess hormonal secreting tumors would present with subtle cardiac signs, and unless you look for them and investigate them, you could miss them. There's an increased amount of stress on the cardiovascular system from either the growth hormone or the ACTH secreting tumors, both in terms of the size of the heart and the functionality of the heart. The D stands for neurological evaluation. So the pituitary just sits behind the third ventricle. So any major increase in the size does cause hydrocephalus and subsequent symptoms. So a neurological evaluation and a full assessment is mandatory. The E stands for full endocrine assessment. So most of these patients that come for anesthesia surgeries go through an endocrinologist where the endocrine nature of the tumor is evaluated. And that is also our responsibility as perioperative physicians to make sure that our endocrine workup of the patient is complete. And the labs include an extensive list of hormones, the growth hormone, the TSH, the ACTH, the prolactin, the luteinizing hormones. These are just a few to name. The F I have put in bracket. That's more in terms of coming on later, but I would just broadly keep the preoperative evaluation here. Stressing more about the key problems in preoperative evaluation to focus is the airway. For instance, one of the key conditions that comes to us in pituitary surgery is acromegalics. They would be predominantly be having problems due to big tongue, big jaw, so prognathism, macroglossia. The soft tissue muscles around the pharyngeal walls will be swollen and bigger, and the vocal cords actually are maybe not as big, and in some conditions could be reduction in the size. Laryngeal nerve palsies and thyroid are also being concomitantly reported for such conditions. You could see the challenges of what obstructive sleep apnea does to these patients as well, and that also needs to be kept in mind. The cardiovascular system, as a result of the comorbidities from the A and B could present on its own with features of cor pulmonale and the stress on the right heart, or on its own because of the hormonal challenges. You could have left ventricular hypertrophy, which is very common. You could have conduction disturbances. You could have cardiomyopathy. And if very late onset presenting conditions, you could see subtle signs of heart failure as well. So a good clinical examination of the cardiovascular system is a must, and targeted investigations with basic investigations like an ECG. And if you're worried or if symptoms produce, then functional assessment of the myocardium, like a dobutamine echo or further on, can be done and tailored for each patient. A neurological examination is a must, and documentation of the same is equally important, because unless it's documented, it's not known. So changes in neurology post-op would not be appreciated. So raised intracranial pressure signs of hydrocephalus, visual field defects, electrolytes, because these do fluctuate sometimes in pre-op status as well. And these form a part of the neurological evaluation. So once you've assessed that, this is the basic minimal workup that's required for the patient. So the usual blood tests along with the hormonal workup in conjunction with an endocrinologist is required. There's a lot of literature available about the steroid administration, and the stress dose, which is talked too much about it, is now actually hardly used, I would say, because the patients are well worked up, and routinely we do not give the usual high doses of steroids, unless, of course, the steroid levels are low in the body. Routine steroid doses, higher doses are not required. Supplementations are targeted to the level of cortisol levels. So unless the levels fall below 200 or 100, the higher doses of steroids would be given for a longer period. Cortisol levels more than 300 or 400 generally do not require extra supplementation. What is also required at this level to know is the equivalence of steroid doses in terms of the steroids available. So the patient is on prednisolone, how much does that equivalent to a hydrocortisone and dexamethasone is a basic that must be known as well, so that you can convert those doses and from your pre-op evaluation into your intra-op status. So coming to the part of how do we actually do it. So I think the part before this is much more important as to what should be known, and how we work up these patients is very important. The objective or the aims of the anesthesia is to give an anesthesia for the surgery, which is predominantly minimally invasive, but can be challenging. So our aim is to provide an anesthesia which is hemodynamically stable, which doesn't fluctuate our ICP, which keeps the brain relaxed, gives you control of the airway, both during the start, throughout, and during the extubation stage as well, along with the challenge of a shared airway. So surgical approach is as I said, was 90% is transnasal, transsphenoidal. So you go via an endoscope through the nose. 10%, I would say nowadays, get open or less than that, predominantly due to the size of the tumor or failure of the surgery through the endonasal approach. So the anesthetic management must have a preparation key for the incidence of an open surgery if it's required. Certain surgical considerations are, we have slight head-up tilts, although the literature says risks of VAE, but considering the other sitting procedure or semi-sitting procedures that we do in neurosurgery, this is probably among the minimal ones, unless there is a lot of vascular infiltration or exposure during the surgery. There's a lot of local infiltration in this surgery, especially in the endonasal one. So you must be prepared for a lot of vasoconstriction resulting from adrenaline that is being injected throughout the surgery, not just at the start. And some amount of preparation is done by our end as well in terms of the nasal drops. It differs from practice to practice. So how do we go about it? The induction part is like any other neuroanesthesia practice. It has to be a smooth induction. The airway can be challenging depending upon what the primary condition is. I would say what I would encountered in my practice is that you would not find the intubation as challenging as you would find the ventilation, especially in conditions like the acromegalics or the Cushing's. So you've got to prepare for the ventilation very well. I am a person who would say that if you are an anesthetist with 5 years under your belt, then you should respect your skills and go for what is the best scenario for intubation and go on with the paralysis and do it. The awake fiber optic still is mentioned for conditions of acromegalics and the difficult airways, and that's a decision to be made at the individual level. In terms of monitoring, you need an arterial line is very commonly used because beat-to-beat monitoring is required of the blood pressure along with the control of the blood pressure that is required during this operation. You do need certain amount of hypotension, and this is probably the only operation where certain blood pressure relaxation is agreeable, so that the visual field does give the opportunity for a good or a complete resection. Muscle relaxation can be provided, or you can do it with entirely TIVA if that's available to you. You got to be prepared for blood loss because that can happen very suddenly and that can happen very extensively as well. And there are limited opportunities to control that if one of the certain big vessels are hit during the transnasal approach. And the only options at that point are to do the neurointervention to control blood. The craniotomy at that point takes time and results in major comorbidities. Lumbar drain is a routinely performed or very commonly performed procedure for pituitary surgeries. The timing of the drain is very important. Most people would put the lumbar drain at the start of the procedure at the induction because post-operatively, if it's being done, we would have lost most of the CSF in most of the operations, and it's very difficult to site the lumbar drain because you hardly get any CSF. So the lumbar drain, if needed, should be done initially after the induction before the surgery starts. Now, it can be done at any of these L3 to 5 spaces. The aim of the lumbar drain has shifted over the course of the years. Earlier, it used to be there for surgeons who used to be, who are, I won't call them old timers, but the newer surgeons don't use the technique of injecting the air and pushing the pituitary forward. Some of the senior surgeons do still require that, but that technique is slowly phasing out. So the drain there is predominantly to drain CSF out and keep the pressure low if there are risks of CSF leakage from the site. Same thing I mentioned here is permissive hypercapnia. Sometimes it's mentioned to keep the CO2 high so that we can push the pituitary forward. Again, that concept is fading and we no longer do that because of the problems of hypercapnia. So the aim of the lumbar drain is to keep it as a backup in case there is CSF drainage in the post-operative period. Some surgeons probably would still require the lumbar drain, as I said, for the visualization of the pituitary by putting in air. Post-operative considerations are very, very important. The post-op phase is as challenging as the initial phase, and the extubation, if I were to mention here, can be as challenging as the induction because the airway is the most important challenging scenario here, which gets compromised, predominantly because both the nostrils usually are padded. Some surgeons just use the one nostril and leave the other nostril for the patient, although it might not be functionally viable. So it's very important in the preoperative evaluation to explain to the patient that they will not be able to breathe through the nose at all, and they need to remember to breathe through the mouth. You need to say to them at least 4 or 5 times, and when you're waking them up, they might remember that. I put an oral airway as a routine for these patients and wake them up on a slightly deeper plane and let them breathe so that the challenge of a spasm or an airway loss can be better managed, because remember, you don't have the luxury of a nasal airway in this circulation. On top of that, you've got trickles of blood going down at the back of the throat, which makes life very difficult and it's very uncomfortable for the patient. And that twilight zone, the complications of spasm do happen. So if you were to classify the complications, I would say the immediate complication is management of the airway, which gets compromised because of spasms very commonly if you are not on the job completely switched on. The subsequent subacute complications that happen are CSF leak, and the later complications that happen are meningitis. So you do have these patients coming back to you for leak procedures or with meningitis subsequent to leak after 5 to 7 days. Usually pain, nausea, vomiting aren't that much of consideration, that much of a problem. Nausea, vomiting would be a problem if a lot of blood has gone down into the throat, and that becomes a concern. So the throat pack that you put in the start would help a lot in terms of loss of blood into the gastrointestinal tract, causing vomiting. In the subacute part of the postoperative stay, one electrolyte that needs keeping a good check on is the sodium, predominantly hypernatremia from the condition called diabetes insipidus. It does present in about 10 to 15% of the patients. And if you were to predict, the size of the tumor has got nothing to do with the incidence of DI in the postoperative period. General belief is that the bigger the tumor and the higher chance of DI and is false, and there's enough literature to prove that. So it's very difficult to predict which patients are going to go into the DI spectrum. Generally, about 6 to 8 hours into the postoperative period, the urine output starts to increase. So what you need to watch is urine output. If it goes beyond 2 to 3 ml per kg per hour for a couple of subsequent hours, then you need to start raising the radar for DI. You need to watch the serum sodium. If it starts to hit 150, you need to inform the surgeons and start thinking about DD-AVP to reduce urine output. The other two sodium conditions in which the sodium goes down is SIADH and cerebral salt wasting. These two conditions don't happen as often as the diabetes insipidus. So these two conditions still need to be kept in the radar, but they are not as often as the DI. So in DI, the sodium is going one way, that is up. And in these two conditions, the sodium is going the other way, which is down. The only way to distinguish these two conditions is the clinical volume status. And you must remember, SIADH is a hypervolumic state, while cerebral salt wasting is a hypovolumic state. And that is important because the treatment, again, is contrasting for both these conditions, and you need to send the osmolalities and urinary sodiums to get to that point. But what clinches the diagnosis is the actual clinical volume status between these two conditions. Thankfully, especially in pituitary surgeries, these two don't happen often. Coming to the morbidity or mortality of pituitary surgeries, mortality thankfully is very, very less. It does happen when there is catastrophic blood loss, especially with the less common pituitary tumors or the pituitary fossa tumors. I would say craniopharyngioma is not a pituitary tumor, but it's still around the fossa, and the approach is the same. And the two near misses, near deaths that I have seen has been from the craniopharyngiomas during the TNTS approach. And that's why preparing for a major blood loss should always be a priority during your induction, because that when happens profusely, extensively, and very suddenly. And it's very difficult even for the surgeon to manage. They don't have options to control that apart from packing. And if they've hit a major carotid branch or the carotid, then the only thing that saves them is the trip to the intervention lab by doing end artery occlusion. Minor complications are CSF leaks, meningitis, and nasal issues. So some surgeons do the surgery along with an ENT surgeon who makes the way and drills the hole into the sphenoid, and the neurosurgeon goes in beyond that point. Some neurosurgeons will do it all throughout and create the passage there for themselves with the nasal passage and then going beyond. So what I would say, the key Key tips for this procedures in terms of management of airway: the ventilation is a major challenge for the hormone secreting tumors and not the intubation. And you should have enough strategies under your belt for managing ventilation. If for most of the trained anesthetists, a muscle relaxant approach should be acceptable. I won't go into that debate. This is probably only neurosurgical condition where I would accept a relative hypotensive anesthesia to facilitate surgical exposure and surgical resection. Prepare, I would say, for two conditions, that is an open craniotomy, which might be needed, and a hemorrhage. So a big IV access dedicated for the tumor. Don't be fooled by a small pituitary and which might be a quick job, because those are the ones that actually can cause trouble because they're difficult to find. The timing of the lumbar drain is very important. Don't wait for a lumbar drain to be inserted after the procedure. You will struggle to get CSF, and the insertion or the accuracy of the lumbar drain will always be under threat. Extubation strategy has to be thought through as importantly as the intubation. If you do not have an extubation strategy in your mind, and if the patient goes into laryngospasm, which is very common in this operation because of the posterior pharyngeal trickle, remember you've got only one natural airway, that is the oral airway. And if the patient is under spasm, then it's very difficult to break that spasm unless you reparalyze that patient. Lastly, but the most important part I have put is remember the throat pack. You'll be surprised how often the throat packs are missed. I have a patient safety angle, and I would say that here as well. Throat packs are notorious to be left behind, especially in longer procedures and when multiple personnel are involved. So throat packs, when inserted, they have to be inserted for all of these cases. They should be recorded onto the surgical safety checklist. They should be made a part of the scrub count. So not just the anesthetist, but the scrub staff need to be involved, and it should be put onto the operative board, count board on the theater. We usually say there is no data and there is lack of data, but I was glad to find some data on this from our own Indian setting. There was a recent paper on the current practices and beliefs of oropharyngeal packs, not just for this surgery, but the overall use of throat packs coming out from a reasonable center. And this was a survey of about 700 anesthetists, and about 300 of them responded. And from the one point that came out, and which was very interesting, was if you see 93 of those or 300 said that they have encountered retained throat packs for various issues, whether it was a change in operating room, operating theater, change in anesthetist, change in the nursing team. And it led to an airway obstruction in 38% of those cases. So it's a huge challenge. Only 200 or odd anesthetists responded to that survey of 700 sent out. So you can imagine the problem is much widespread. So throat pack, remember to put it on the board and take it out. So in summary, pituitary surgery anesthesia requires a comprehensive evaluation. That's where the key lies. Forward planning is required, especially for the airway, both intubation and extubation. Remember to put the throat pack, put it on the board, put it on the surgical checklist so that it can, you have one more person to remind you to take it out. Oral airway augmentation is required in the post-operative period. So the management of that starts from the pre-op period, where you got to remind the patient that he has to breathe from the mouth, and you have to have strategies for your oral airway. Post-op surveillance is extremely important for pituitary surgery, especially done through the nose, where you have your acute challenges of airway and you got subacute challenges of CSF leak, meningitis, and sodium disturbance. Don't send the patient back home in the lumbar drain. It has happened. When the lumbar drain was just left there, not connected, patient went home with that. It has happened. So remember that as well. And hormonal checks are required in the post-operative period as well, not just pre-op period, to see the patient is safe to go home. So with that, I would conclude. Thank you very much. Sorry if I had exceeded my time.
Thank you, Gaurav, for a very comprehensive presentation on pituitary surgery. And pituitary surgery, I have also seen a death after pituitary surgery because of hemorrhage. And it, as you very rightly said, it's very much possible to have a mishap because of hemorrhage. And the surgeon operates in a relatively blind area, though he may be seeing in the microscope, but it's not easy to control hemorrhage in case it happens there. And it is lying next to the operative chiasma as well as important blood vessels. Thank you very much once again, Gaurav. So we come to the next presentation. The next presentation is about Dr. Ketan Kulkarni, and he'll be talking about something which is not very commonly done in most centers in the country. And he's going to talk about craniosynostosis. And craniosynostosis is a relatively less common anomaly which is seen in the children, and it's a congenital malformation. And basically, there's a problem with the sutures of the skull bone, which are fused and which do not allow expansion of the brain. And Dr. Ketan is going to present a case in which there was it's not just craniosynostosis, but he's also going to present a reference case kind of thing, which has also got hypertelorism. And Dr. Ketan is a pediatric anesthesiologist. He spoke last time also. And he is again, he's one of the first DMs from in pediatric anesthesia from India, and he trained at KEM Medical College in Bombay. Thereafter, he was working as a consultant in NHS, and after that, he wanted to come back to India, and he joined us at Amrita Hospital. Over to you, Ketan. Ketan, you are mute.
Sorry. Yeah. So thank you very much, organizers, for giving me this opportunity. And today we are going to talk about craniosynostosis, CS in short. So what I am not going to cover, usually the presentation starts with what I am going to cover, but what I am not going to cover today is what is craniosynostosis and what are various types of craniosynostosis. Gaurav, I would die rather than classify. So yeah, you can punish me for that. And then various surgeries according to age. More or less, anesthesia wise, it doesn't really matter what type of craniosynostosis it is, or those various surgeries according to age. It is kind of a surgical decision, so we don't interfere into that, but our anesthesia management remains more or less same. So that's why we will focus more on the anesthetic part. If you see cranium broadly can be classified into three parts. One is neurocranium, one is face, and one is oral apparatus. However, the surgeries of oral apparatus, like if there is small mandible where we use mandibular distraction or TM joint oncolysis, or if you see the face where there is cleft palate, cleft lip surgeries, kind of surgeries, that is a different spectrum. But if you see anything above the maxilla per se, their approach, their surgical technique, everything is same, and that's why our anesthesia management is also same. So we'll focus on anesthetic craniosynostosis than actual definition-wise craniosynostosis where the sutures are fused. So let's start with a case study. This blessed child presented to us. He is a 4-year-old with facial bipartition. And he came in for corrective surgery. There was a huge distance or a huge gap between his orbits, and the gap was around 66 millimeters. Usually more than 40 millimeters is considered as severe. So this is how he looked from the front. This is how his oral cavity looked like. There was a huge cleft palate, and then this is how he looked on the CT scan. Problems which were faced by him is vision problem. He did not develop a binocular vision. There was a huge basal encephalocele. There were feeding related problems and speech related problems because of the cleft palate and malocclusion of teeth. And socialization was again a challenge because people used to call him by names and everything. Generally, whenever you are dealing with any craniosynostosis, it's usually to prevent the progression of abnormality. It's either to correct the abnormality or to reduce the risk associated with raised intracranial pressure. Now, particularly in our case, it was to correct the abnormality and to reduce the risk of problems associated with the raised ICP, like rupture of basal encephalocele and problems associated with that. It's whenever we are dealing with craniosynostosis surgery, it is a multidisciplinary approach. It is not like only one person can solve all the problems. It's not a single person centered kind of thing. Here you need to have a good plastic surgeon, a good neurosurgeon, a decent enough our PICU team, and all other the infrastructure of the hospital. So it's not one person who can solve the problem. This is something I would thank my surgeons here, because they tell us about the planning. They first initially present all the virtual, they do a 3D CT scan, and then they present us the virtual planning of the surgery. This is our patient looked like from the front and from the top. Now the surgical planning was this red color part they planned to remove, and the rest, the two sides of orbit and maxilla, the plan was to rotate them inside. And this is how it looked from the back, and this is how it looked from the top. They also did a 3D model of this particular thing, and then they did a surgery on this on model, and then we discussed all these things in our team brief, or not team brief. We discussed well in advance, where we thought it through. We started with the end in our mind, like how and which tube we are going to put in, how it's going to be fixed. Most probably this patient will need ventilation for a couple of days. So we all thought through. Usually craniosynostosis, we prefer nasal tube, but unfortunately in this case, it was not possible. Having a oral tube, normal or flexometallic tube, there is a chance of accidental extubation, or normal tube can kink. So that's why we decided to go for a South Pole. And tracheostomy, we particularly decided that we will not go for elective tracheostomy, because in the post-op it increases the complications, and it's very difficult for a kid to communicate when they are having tracheostomy. So that's why after giving it a thought, we decided we will not do a tracheostomy straightforward. Elective tracheostomy, we'll do it if it is required. We also formed a WhatsApp group, and we believe that this helped a lot. And we have basically made it as a protocol. Like after this case, we have, whenever there is a major case, we have started doing this. So plan for this particular case was hypertelorism correction of basal encephalocele, repair of lip, repair of nose, and improve the quality of life. Again, there was a discussion about cleft palate repair, but everyone came down to consensus that this might not be the best time to do the cleft palate as well in the same sitting. So we thought we'll come back for this at later date. Now anesthetic implications, they more or less same for every CS. Difficult airway. Now, if you see, only 20% of the cases are syndromic. Of all the craniosynostosis, only 20% are syndromic, 80% are non-syndromic. So those 20%, they will have difficult airway. Otherwise, most of the kids, they will have normal airway. In this particular case, there was a large movement of facial structures. So post-operatively, the airway edema will be there, and it will get complicated. Especially when CS is done in the prone position, again there will be airway edema because there is a lot of fluid shifts happen. We also thought of third nerve issues when there is orbital relocation, ICP issues and seizure risk associated with it. This is common for every CS. It's not just for our case. And again, this is again common for everything: significant blood loss, risk of massive hemorrhage, air embolism, thromboembolic issues because of the patient stays still for a long time. Pressure areas, pressure source per se, temperature management. The temperature drops down to like anything. We have to be very, very careful about the temperature. And long surgery, we like the human factors, because you are not thinking straight at the middle of the night when we have started the case at 8 o'clock in the morning. Optimization, usually CS patients are nutritionally depleted. They have low hemoglobin, so you need to correct them, correct their hemoglobin and other nutritional parameters beforehand. There is also some component of URTI. This case also, we had to postpone him because he developed upper respiratory tract infection, for which he got admitted. So in our institute, we follow 2 weeks of symptom-free period. Like they should not have any respiratory tract infection, which causes fever, lethargy, any hospital admission or requirement of antibiotics. So we don't do for next 2 weeks. And suppose if there are not having any symptoms for 2 weeks, we do that. Perioperative autologous blood transfusion is again, it's of no role per se in craniosynostosis. And I'm not sure that any of the boiled centers do it. We don't do it, Amrita. Anesthetically, assessment wise, we did CBC coagulation cross-match, again the important thing of cross-match, RFT LFT to have as something as a baseline, because if there is a massive transfusion, then the liver and kidney can get hit and we need to have something to start from. So that's why we did RFT and LFT. Echo LV functional assessment we did on table. When we put in the central line, we usually confirm our central lines with the with echocardiography, and that's when we did our LV function assessment. Since the patient was not syndromic, we didn't ask for any cardiology per se opinion. We need to have adequate venous access. Now, adequate is again a vague term, but usually what we have found out is 2 big peripheral lines with 1 central line, and art line usually suffices. Plus ET according to the surgery. Rice tube, we definitely want it in because we start feeding them on day 2. ABG, repeated ABG are required. Rotem and take, anything whichever your institute prefers. Unfortunately, we didn't have Rotem or take for this particular case. We eventually we mobilized it. A non-invasive cardiac output monitoring is of again it's very limited evidence to show that it is useful in pediatric patients. TOE in this, it's of again there is limited value to it because it's very there is no space basically for to use. Induction for this particular case, we did IV induction. Kid had already got an IV line in because we did his cross-matching a day prior. Face mask ventilation was a bit tricky. We'll show you how we did it. And it was straightforward laryngoscopic, video laryngoscopic intubation. And then we did the lines. So face mask ventilation was, we had to change 2 face masks before we got the adequate seal. And once we got the adequate seal, it was pretty straightforward. We paralyzed this patient before we attempted the video laryngoscopy intubation. This is how his airway looked. And this was the face mask we used. This is his intubation video. I think the challenge while negotiating the tube, because it was a south pole tube, and the maneuvering was a bit tricky, so that's why it took a little bit of extra time. But I think it was not that challenging. Negotiating through the basal encephalocele without causing any damage to it was the trickier part. And we also do this in terms of fixation wise, because it's a long-standing surgery and there can be a pressure sore on the lower lip. So that's why we put some jello net just to prevent the pressure sore. Lines, we prefer left-sided brachiocephalic vein. IJV is suboptimal because if first of all it comes into the surgical access wise, and then functioning, we need, suppose if there is a, God forbid, air embolism, we need to aspirate that. And if IJV is there, they're put on the drapes and everything, the aspiration part becomes difficult. So that's why we prefer the brachiocephalic, which is away from their surgical field. Again, it's better to have the tip of the tip of the central line into the right atrium. But if you are putting central line from the right side, then the tip, there is a high chance that the tip migrates down and goes into the right ventricle. Now, if you pull it out, there is a chance that it extravasates in the subcutaneous tissue, and there are reported case reports that it has happened. And when I was working in Liverpool, again they did not report it, but there were quite few cases of extravasation from the central line. And we put ladder flex because it stays in for a long time, and we need it for the post-operative period as well. So these are some few reports of extravasation from the central line. Maintenance, it's mainly TIVA-based anesthesia, propofol and fentanyl. We don't have REMI here, so propofol, atra, TXA, tranexamic acid, that's what we used for this particular case. Sevoflurane we gave intermittently, only during the initial bits where they did the craniotomy and scalp, like scalp incision. NORAD, adrenaline, and a syringe of saline, just in case if we need to put in some vasopressin, we kept ready. Fluid warmer is a must for these cases because that's the main thing where how you are maintaining your temperature. And cell saver, we used it for we rented this out, but we'll get it in the future. A cell saver is, I think, is a good thing to have, especially when we are doing these cases. We personally, at least I personally believe in automation, so there is less risk of errors, and there is a not many fluctuations when you are giving drugs or even fluids per se by using infusion pumps. Blood conservation strategy, we can, as an anesthetist, also can help the surgeons. The surgeons have to have good surgical technique. They should know when to use Surgicel and bone wax and not just blame it on the anesthetist to reduce the blood pressure. We can use we have to use tranexamic acid, and cell salvage is another thing. The cutoff limit for transfusion is 10 gram per DL. That's what we follow. And this is a standard biocoronal incision. It starts from one mastoid to other, like opposite mastoid. And this is how they have marked. This part of the cranium will come out. And then this, now they have done this craniotomy. This central part, now they will remove this, and then the two halves of maxilla and orbit will be moved in the center. So here they have moved the two parts of the maxilla in the center. They have corrected the basal encephalocele and put in a graft to solve the problem of the cranial base. Unfortunately, in this case, there was some signs suggestive of raised ICP, and there was non-reacting pupil on one side. So we, after doing all the measures like lumbar drain and giving Levipil, like anti-epileptics, controlling temperatures, CO2, PO2, still it was not correct. It was not, people were not reacting. So that's why we decided to go ahead and do a CT scan. So if sometimes you might need to do that as well, and so be prepared, keep things ready in your head, like what all things you will need for the intraoperative CT scan or MRI. And after this CT scan, we could not find many like problems per se. But yes, there was raised ICP sign suggestive of or imaging suggestive of raised ICP. So there was nothing much for us to do at that point of time. So that's why we went ahead and did the facial part after that. So you can see the things started coming together here, and these are like last final mile. So after 20 hours later, we started from this and we finished at this. And at 20 hours, after 3 liters of crystalloid, 2 units of blood, 500 ml of autologous transfusion, we had and temperature of 36.1, I think, which is a nice figure to have. With minimal inotropes, we shifted this patient to ICU. Lactates were high, yes, but then eventually they came down later. So you can see the basal encephalocele is now removed and the divergent optic orbits are now looking in the same direction. And this is how it looked on the CT scan. PICU, like till now we have finished our anesthesia, but it was only like half battle won. In PICU, again, the problems were fluid and inotropes, eye care, physiotherapy and nutrition, and intracranial pressure, which was a problem from that middle of the night. We used like very objective, very objective assessment and goal-directed therapy. IVC echo and B lines on the lung ultrasound. We use it for vasoactive agent titration and giving fluids. Like eye care, we expected there will be some facial edema and we were prepared for that. But in this case, it was like horrible, and we didn't expect it to be this bad. There was severe proptosis. The eyelid got everted because of the fluid shifts. Cosmetically, things started looking very bad, but we just, I think, kept patience. We had to use some Lasix to take out the fluid. We used Lacryzeel and eye taping, and slowly over next 7 to 8 days, things settled down. Physiotherapy played an important role. You can see our patient, he started mobilizing, but you can see that the right side is not moving much. There was a stroke, and there was a weakness on the right side as well. We started the passive exercise right from the day 1, and we also believe in the concept of partners in care, where the parents are parents are taught how to do physiotherapy when they are first presented to us. And here you can see the patient walking with the tracheostomy tube in situ. The recovery was slow, but it was steady. Intracranial pressure monitoring, I think it will take another 2 hours to talk about this, but we used optic nerve sheet diameter to see it objectively. Hypertonic saline Levipil to drug-wise to control all the other physiological parameters, and aggressive fever management was the crux of ICP monitoring, ICP management. Even after doing all these things, we thought, okay, we'll just ventilate him for 24 hours and he will be good for extubation. But our calculations didn't fit. They didn't match. There was a delayed awakening. On 3rd day, we saw that his right side is not moving properly and there was a poor cuff and gag. So we did a CT, and then there was an infarct with raised ICP. So that's why we decided to go ahead and do a tracheostomy. So we did tracheostomy on 13th of Feb. And after like 22 days of in PICU, things started doing well. So you can see his right side has started moving very well, and neurologically also, you can see he's responding to commands, and his right side also started, right hand also started moving. So here his dad is saying to put a backspace and remove or delete everything. Then, so his right side also started moving. So yeah, this is how we did it. A strong team can take any crazy vision into reality. Thank you very much.
Thank you very much, Ketan. Actually, I think we have shown the case, a very typical case of craniosynostosis with hypertelorism, something, a big achievement for all of us. And of course, we have been doing a lot of craniosynostosis in our hospital. This case was a little different, and so we took this as a reference case. Thank you once again, Ketan, and the entire neurosurgery and neuroanesthesia team for looking after this child and having a very good outcome. So we proceed further with this webinar, and we have the third presentation. The third presentation is by Dr. Rahul JS. Dr. Rahul is a DM in neuroanesthesia. He did his DM from All India Institute of Medical Sciences. Before that, he did his MD from PGI Chandigarh. Dr. Rahul has a keen interest in, of course, neuroanesthesia, which is his branch. Plus, he's also a very good singer. He used to run the band in PGI Chandigarh. Over to you, Rahul.
Thank you for the kind words, sir. So without taking much time, I would like to start my topic, which is positioning in neurosurgery. We bring greetings from Amrita. So generally speaking, positioning is a responsibility of both surgeon and anesthetist. Let's start with that it's a multidisciplinary team approach, and it's often treading a delicate line between the optimal access versus the safety of the patient and ensuring the physical and physiological safety while we're at it. So the challenges that one might face in positioning, or what we face in neurosurgery on a daily basis, is obviously the access to the airway, access to the patient, especially for monitoring and for resuscitation, ensuring that the cerebral venous drainage is adequate, because in most of these positions, the neck is twisted and turned around, and of course, avoiding the pressure on the nerves and the bony structures and preventing and treating position-specific complications. So these are the various positions in neurosurgery we use on a day-to-day basis, which will be discussed one after the other, not taking too much of time. So the head positioning aids that we have at our disposal in neurosurgery includes from the head ring, which is the silicone head rings, to the head rings used for the horseshoe frames, as well as for the spine, the foam headrest, as well as the pin holders, which are the Mayfield and the Sujita. These are two available at our disposal. So the head position in supine position, though the patient is supine, as I said, the head keeps getting tossed around and it's never in the bang in the middle. The head neutrality is sort of a myth, even patient being in supine. For the sake of the access, the head could be neutral in few cases, like when the surgeons are trying to do a bifrontal craniotomy for accessing the frontal aspects of the brain. They may also do some head flexion for the frontal lobes, for the anterior hemispheric fissures, and there could be head extensions, especially when they're going for the skull base and the subfrontal approaches, and head may be turned around to the contralateral side, especially when they contemplate a so-called for the frontotemporal incision to expose the frontal and the medial parts. So in supine, the bony prominences quickly going from supine, though supine is deemed to be one of the most harmless positions that there are. However, the bony prominences still needs padding, like the olecranon, the occiput, the sacrum and the coccyx, as well as the calcaneum. Arms need to be neutral if abduction is needed to be put less than 90 degrees, and tension at the neck to be minded. As mentioned, the head will be tossed around, so the tension of the neck is of importance to be given. So there are variations to it: the horizontal, the launch chair, and the reverse Trendelenburg. More often than not in today's day and age, we follow a launch chair positioning in which the back end is slightly elevated with sort of a reverse Trendelenburg with knees flexed. So the knee flexion essentially reduces the stress on the lumbar spine, the hips, and the knees. And also the slight head elevation, the slight reverse trend kind of improves cerebral venous drainage. So this is one position, it kind of essentially causing good cerebral venous drainage with adequate amount of venous return without actually compromising or causing any stress. So lawn chair is more often the supine as we speak is the lawn chair position. Then reverse Trendelenburg is very seldom used in today's day and age unless the table gets stuck in that position. It does have the advantage of an increased cerebral venous drainage, but of course at the cost of a reduced venous return, which may cause hypotension, and also the reduced cerebral perfusion that might ensue because of the hypotension. So the preventable complications that there are some really funny and rare complications like the so-called pressure alopecia, which has been reported in a few of the so-called safe supine surgeries, where because of lack of adequate cushioning of the occiput, there has been pressure alopecia, and of course the back pain, especially in a straight supine without the lawn chair positioning. There could be back pains, ulnar neuropathies, and stretch injuries to brachial plexus if the extreme neck rotations are not taken care of. Coming to the lateral position in neurosurgery, going lateral. So lateral position is something which is often used for most of the neurosurgeries, like the temporal lobe axis or the skull base and CP angles with some tilt. And also aneurysmal surgeries, especially the posterior aneurysmal surgeries, and also in some spine surgeries where they need a retroperitoneal approach for the thoraco and lumbar surgeries as well. In the lateral position, the difference here is obviously here the patient is on the head ring, and when you use pins to fix the head, it gives us the luxury of being able to hang the head by the side, which kind of reduces the pressure on the axillary nerve. So this is a lateral position in which there is an axillary roll. More on that, the axillary roll is slightly above from the axilla. It's a misnomer, so axillary roll is never in the axilla. And it is slightly away. So the axillary roll essentially is trying to prevent the pressure in the axilla. So axillary roll is actually not in the axilla, it is somewhere slightly below that. Apart from that, the back and the abdomen well supported. The bottom knee is bent again for the same reason of reducing the tension on the spine, because most of the surgeries go for more than 6 to 8 hours. So essentially we're trying to ease the spine. At the same time, we're having to pad both the knees as well, because they knock each other and kind of cause common perineal nerve injuries as well as the lower limbs. So coming from lateral, if you tilt the head further down, there is something called as a park bench position. So wherein instead of the head, which is facing 90 degrees, the head starts looking down. So the aim of this position is essentially from lateral, where the patient's trunk was perpendicular to the table, is tilted further down by a few degrees, 30 to 45 degrees down. This essentially causes or lets the neurosurgeon access the posterior aspect or the cerebellopontine angle and the cervical region as well, without causing the patient to be made into a full prone. So this is also most widely used for CP angles as well as the posterior fossa tumors in today's day and age. So park bench also has similar kind of concerns, where we kind of give rest to the arms, ensuring that the abduction is not going beyond 90 degrees, and the dependent arms hanging off the table just like lateral, and there is axillary roll away from the axilla, and the bodies and the torso is supported with pressure points well padded also. And yes, in this, the ipsilateral shoulder, sometimes this is important. One important consideration one often forgets is often to open up this area where the surgeon is trying to do. They tend to pull the shoulder down and strap it to the table. So this is again an important thing to remember to prevent any stretch injuries on the brachial plexus, especially these surgeries which go on for more than 8 to 10 hours and sometimes change the dates as well. So coming back, because it's an important point, so I decided to say it over 3 slides, that axillary roll is not in axilla. So the axillary roll is somewhere below it, because the idea is to keep the axillary, keep the brachial plexus clear of any kind of unwarranted pressure. So the dependent arm, so we ensure that there is clear space between these positions. So the complication, as I said, brachial plexus injuries, stretch injuries, and there's definitely the VQ mismatch, which is a challenge, especially the dependent lung, which can have problems with perfusion, problem with ventilation. There could be shunting, and eventually there could be lung collapse as well if it's a very prolonged surgery. That is something to be borne in mind as well. So semilateral, again, from lateral, from park bench, we come a little more up. This is the semilateral, or called the Janiras position. This is essentially a supine with a little more than usual flexion when one is needed. This is about 45 degrees supine. Here also, essentially, all the principles remain the same, where we pad the pressure points and ensure that the neck is not stretching or pulled out. Then the prone position, which is neurosurgeon, the spine surgeon's favorite. So in neurosurgery, the occipital lobes and the posterior fossa, the upper cervical region, gets exposed in prone position. And also most of spine surgeries, even today's day and age, are still does a good proning. So patient is often induced in the trolley, and once the tube is adequately secured, we position a bite block. This is something which in today's day and age we cannot miss, considering the amount of neuro monitoring that there is, especially in MEP monitoring. So technique of proning, or any position for that matter, there is adequate personnel that is needed, adequate filling before you prone the patient, because of to prevent the unwanted hypotension that might ensue. And the ventilators and the monitors, and then will be need of ECG and SpO2 during the turning. This is the usual recommendation. However, there is individual differences which would exist. And obviously the arms held by the side, and the head maintenance as still plane, and rotating the entire body as one piece in one go. And most important thing is one call, one team, which we here follow it rather religiously, where because we know the chaos can be catastrophic. So one person calls out, and everybody else follows with that one person while the turning is being done, to avoid unwanted pulls and pushes. So coming back to our original, so the prones can be done in two ways. Either you fix a frame where the head is pinned to a frame, essentially for the neurosurgeries or the cervical spine surgeries, or you can put it in a foam-based headrest. Essentially, more or less, the principles would remain the same, that the arms would either be side in terms of a pins, or they could go in the go forward, like the so-called Superman position. But other things like avoiding the pressure on the abdomen, avoiding the pressure on the male genitalia or the breasts, and padding off the pressure points, as we've discussed, is to be done as it is. One extra point, which is the most important in prone position, will be especially when we're using a bolster or we're using a headrest, ensuring that the eyes are free, that most of these headrests comes with a mirror underneath. So one needs to have eyes in vision. Eyes need to be clear to ensure that there is no post-op vision loss. Having said all this, remember the chin. As said, in today's day and age of neuromonitoring, especially in transcranial MEPs, where usually a voltage range of 500 to 600 volts is used to stimulate the scalp, you see most often the patient is not on relaxant and he bounces. So this happens a lot of times, and it eventually causes a chin to erode. This is something which we do here as well, where we ensure that the chin is adequately well padded to prevent any inadvertent chin necrosis. So we've covered it. So yeah, this is the kind of position the heads, the limbs we would want. We wouldn't want inadvertent excessive abduction, and also that it has to be in level with the torso as much as possible. Yes, and regarding the bolsters, the bolsters have to be planned according to the size of the patient, and most of the institutes have standard bolsters. So the bolsters may have to be pre-formed and pre-planned according to the patient's BMI and the weight, because the idea of bolsters is to carry the entire torso between the thoracic cage, not the shoulders, between the thoracic cage and the bony pelvis, and the abdomen needs to be hung freely. Because the abdominal compression will increase the venous pressure and will, especially in spine surgeries, this can have a bearing in bleeding. The patient will keep bleeding because there is no way for the tummy to be free. And genitalia to be kept clear as well, and don't forget the pumps. And the sternal notch is something which I have learned here, is something which we again do here religiously. We ensure that the sternal notch and the bolsters are at least 2 to 3 fingers spaced away, because that also being a pressure point can have, there is a potential for necrosis. So sternal notch is something we need to do. So yeah, going by what I previously said, there's abdominal compression, which reduces the venous return and the cardiac output. And also it has a bearing on the ventilation as well. Especially this is important to remember in pediatric population, where if the bigger sized bolsters are used, it kind of sometimes takes over the entire thorax and extends onto the abdomen. And we suddenly see that the peak pressures have gone up. It's essentially the bolster not letting the patient to ventilate. So that is something which we need to keep in mind when we kind of tailor the bolster size for the patient's body habitus. And the increased venous pressure will also cause raised intraocular pressure. There could be venous engorgement, which would cause arterial compression, which would lead to something called as ischemic optic neuropathy. And as well as there could be some inadvertent extensions and inadvertent neck movements, which can cause the upper airway edema. So the complications we've already discussed: perioperative vision loss, airway edema, macroglossia, and inadvertent exchange. Just one important thing here to be borne in mind, especially when the patients are on pins. If the tube is not fixed, there will be a lot of salivation, there will be a lot of trickling down of secretions, which can loosen the things, and it has happened and it has been well reported that there could be a loss of airway in prone position, especially with pins. So there's something to be kept in mind, especially with patients for long duration surgeries, because there's no way one can intubate in that position, and we might run the risk of losing the airway. So that is something to be borne in mind while we prone a patient. And of course, the dislodgement of invisible lines as well. So a few lines on post-op vision loss. As said, this can be often much seldom. It happens less than 5%, but when it does happen, it is often career-changing, and it is often career-defining for the anesthetist and life-defining for the patient himself. So usually, it's a painless loss of vision, which is seen right after the proning position. Most often occurs because of ischemic optic neuropathy, followed by central retinal arterial occlusion. And in few patients of extreme stage, or especially in a part of the press, which is the posterior reversible encephalopathy syndrome, there can have a cortical blindness as well, especially if there is an embolus of PCA, especially if there is any thromboembolic risk. So risk factors of POVL, this is important for us to understand, especially while doing the doing the PAC, to identify the high-risk groups, the extremes of age, the obese patients, and patients with vascular risk factors like diabetes, hypertension, hyperlipidemia, chronic smokers, tobacco chewers, CEDs. All these are at risks of developing a POVL. And the Wilson frame use. Wilson frame. This is a Wilson frame where instead of a bolster where the patient is made to prone, is notoriously said to sort of listed under the risk factors by the World Journal of Orthopedics, where they say that the head position in comparison to the heart is slightly lower in comparison to the bolsters. So Wilson frame is known to be a risk factor of POVL, and of course the longer duration of surgeries and the blood loss, which can cause hypotension and eventually it might lead to POVL. Other risk factors: inexperienced surgeon who is taking a longer duration of time, emergency surgeries where the optimization was not possible, and the comorbidities, the risk factors might have been missed, and the direct ocular compression and hypotension leading vasopressors, which also has a risk factor for ischemic optic neuropathy, and the anemia because of the hypoxia it ensues. Then concord position is essentially the prone with some sort of reverse Trendelenburg with neck flexion. This also kind of opens up the back part for the surgeons to access the occipital region, the brainstem, and the posterior fossa. And also, one thing important to remember in concord position is ensure that there's at least 2 to 3 finger breadth between the chin and the sternum. This is important to ensure, and always ensure that the peak pressures remain at the same level before turning, to ensure that there is no inadvertent increase of peak pressures or any fluctuations. Then arms tucked, knees flexed, as we mentioned. The sitting position, we come to the last position of the day. The sitting position, especially for the supracerebellar and infracerebral regions, especially somewhere on this plane, is said to be most easy access. At the same time, because of the gravity, the cerebellum tends to retract. So it gives much lesser retractor pressure on the brain parenchyma, while also reducing the duration of surgery. These are some of the advantages why sitting position became popular. However, there are disadvantages, and because of consequences, and also with availability of newer positions like park bench. Sitting position is, of course, still done by many centers, but it's largely put out as we speak by many of the surgeons across. Yeah, so for the midline structures, two of course, and yeah, one important point for sitting position is when you make the patient is sort of put in a semi-sitting position. It is not the conventional sitting as described, which is usually a 70 to 80 degree head up. So this sitting position is essentially a modified sitting now. It is essentially a 50 degree to 45 degree with some head flexion and with flexion of the lower limbs as well to facilitate venous return. Important point to remember is the head holders to be put on the side of the back, because in time of an emergency, because venous air embolism is a very dreaded complication sitting position, we want the bed to be put up straight in a matter of seconds. So to facilitate that, this has to be put here, because if this is fixed here, the A is the correct position. So if the head were to fix to the distal part, so to speak, the foot end of the bed, it would take that much more time and the head is literally stuck. So we are stuck in trying to bring the patient down. So this is something which one needs to put in mind while sitting up a patient. So the advantage, I said, is excellent surgical exposure with very less blood loss with better field. But for the even for the anesthetist, there are a lot of advantages. Obviously, in sitting position, the ventilation is much better, airway pressures are lesser, you're able to see the patient's face, duration is faster, we can go home on time, maybe improved access to the extremities as well, and better access to ETT and thorax as well. There are a few contraindications, not going too much into detail. The complications which are important for us to know, one is the hypotension because of the supine head up, because the venous return has to travel anti-gravity. So there is hypotension. Pneumocephalus is a dreaded complication. But however, based on studies, all the patients sitting tend to have some amount of air. But the clinically relevant causing the so-called Mount Fuji sign, which is obstructing the parenchyma or causing a pressure effect, is about 10 to 20% in sitting position. Then there's venous embolism, which we will deal a little more detail in few slides, and quadriplegia, especially if there is too much of flexion, there could be what is called as a mid-cervical ischemia, which can cause the patient to be quadriplegic because of spinal cord infarction, and macroglossia because of the flexion again, and peripheral nerve injuries. So venous air embolism, quickly in last few slides, is essentially when the head is up in relation to the rest of the body, there is a lot of negative pressure created, because of which the air gets sucked in, putting it very simply or bluntly rather. So this is something in a sitting position with the open sinuses, especially during the surgery, the sinuses are open and there is a great risk of air to get entrained. So based on the type of monitor which is being used, the incidence can be it says 37%, and few literature goes on to say close to 60 to 70%. In fact, when you use TE in a real sitting like position, you actually see the air being continuously entrained. But the ones which are actually causing physiologically relevant changes, for example, drop in blood pressure or causing ETCO2 drop, is at a much higher range. So most of the times, transthoracic echo kind of tends to analyze air embolism. So for all practical purposes, a drop of ETCO2 more than 3, which is sustained without change of minute ventilation, with a drop of hypotension as well. Sometimes with or without hypotension. Sometimes the blood pressure is at the same level and suddenly there is a drop. We might think in terms of some air being would have crept in. So how do you prevent it? We elevate the legs. So the sitting position with the elevated legs is essentially to increase the RF. We also increase the legs immediately to increase the right atrial pressure because we are trying to increase the pressure here to prevent the air from getting sucked in. We increase hydration. We ensure that there are anti-shock trousers. PEEP was initially believed to give the positive pressure to prevent it. However, now we believe that it doesn't help. In fact, it can actually cause the paradoxical air embolism if at all the patient has a PF or some opening between the two sides. And intermittent jugular venous compression is one thing which is usually followed, and management, you ask the patient as soon as we see the ETCO2 drop by more than 3, we ask the surgeon or the nurse to flood the field immediately. We take the patient on to 100% oxygen because we don't want the nitrous to blow up those bubbles, and immediate hemodynamic management, bilateral jugular compression to increase the pressure. So we're doing 2 things. One is trying to prevent further air entrainment. Second is to ensure that whatever is inside we might have to aspirate it, or we might have to prevent it. So there's dural maneuver in which we do a left lateral with slight up. So in that way, it kind of locks, the air kind of gets locked in the RV and doesn't spread further. And chest compressions are previously called the precordial thuds, which is not recommended anymore. But yes, if there is a cardiovascular collapse, one might need to even do chest compressions as well. So the takeaway from the lecture, watch out for the eyes, but not to forget the chin. Make space for the tummy, pre-plan the bolsters based on the body habitus. Positioning is a multidisciplinary approach and not necessarily under who the patient is admitted. And axillary role is not in the axilla, and practice team approach, which can take us a long way. Thank you for your time.
Thank you, Rahul, for a very, very brief and a very nice presentation describing all the important elements of positioning in neuroanesthesia. Positioning is a major thing in neuroanesthesia, especially, and we spend a lot of time in the initial parts of the surgery in trying to position the patient properly so that the surgical access is the best possible. And not only positioning properly is only for surgical access, it's also for to ensure the safety of the patient. This patient should not have any position-related morbidity. So that's a very important thing. In case there are any questions, Rupsa from Planet, can you please share the questions with us on the chat box? At least I can't see any questions on the chat box. So let me give you a summary of what we did today. And the first presentation was by Dr. Gaurav, and Dr. Gaurav talked about something which is done very commonly, relatively commonly in neurosurgery, that is pituitary surgery, and the complications of transsphenoidal approach and the things we have seen very often, not very often, but in hands which are not so competent, we see the complications, and the neuroanesthetist has a very tough time managing those complications. The second one, the second presentation was by Ketan, and Ketan presented something which is relatively rare, and not many centers do craniosynostosis surgery. But it's we've done quite a big series of craniosynostosis surgeries, which we plan to publish also, and they are very difficult ones. Let me tell you, by the looks of it, the child was very difficult. And it's not only the child is difficult, it is the perioperative problems which occur when you do such cases that which make things very difficult. You have to be very alert. You have to manage so many things. And the last presentation by Dr. Rahul on positioning. Positioning we generally tend to ignore. We generally tend to ignore the importance of positioning, and we do not stress on positioning. But positioning is a very important aspect in all surgeries, and neurosurgery especially becomes more and more important. So with that we come to the clinical presentations. Because there are no questions, I would thank you all for being there, and thank you all for giving us an opportunity to present in front of you. Amrita Hospital will always be indebted to Indian College of Anesthetists for giving us this opportunity. Thank you very much. Over to Dr. Jayashree Sood, ma'am.
Thank you, Mukul. Thank you so much for summarizing the webinar today. That was an excellent moderation. And thank you so much, Dr. Mukul, Dr. Gaurav, Dr. Ketan, and Dr. Rahul. Truly, the topic seems so simple that, okay, positioning, what's so big about positioning? But so important, especially in neuroanesthesia. Of course, in all surgeries, but this in neuroanesthesia, we've all seen complications sometime or the other. And so also the craniosynostosis is again a very, 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 very challenging case. And in fact, 2 anesthesiologists are required to conduct this case. And of course, pituitary, not really seen in many institutions, mainly those tertiary care which are practicing neuroanesthesia. So thank you so much for the excellent webinar, and we all benefited. Thanks a lot and good night. And we'll see you next Wednesday again at 7 o'clock. Thank you very much. And thanks, Clarnet. Thank you. Thanks, Anish. Thank you very much. Thank you, Dr. Radhakrishnan, Baljit. Good night, everybody.
Thank you.
Thank you, ma'am.
Thank you so much, everyone, for extending us the opportunity to host the session. See you soon. So with all your permission, I would like to sign off for today.
Thank you. Bye-bye.
Thank you very much.